can start.
Good morning to one and all. Welcome you all to the third AIOC midterm. I am going to present my free paper on comparison of serum and vitreous biomarkers in patients of type 1 and type 2 diabetes mellitus with diabetic retinopathy, and also their correlation with the traditional systemic blood parameters. The co-authors of my paper are Dr. Nawazish and Dr. Shauryavardan Azad. Coming on to the introduction, the estimated prevalence of diabetes worldwide in 2019 was about 463 million, which was projected to increase to about 700 million. And also, as we all know, India is an upcoming diabetic capital. Diabetes is an amalgamation of various pathogenic pathways that interact among themselves and culminate into a numerous complications which are related to the primary disease. So there have been various landmark trials like DCCT, EDIC and UKPDS which have always emphasized on the fact of glycemic and systemic control to control the disease. However, there are certain patients with poor diabetes control who don't progress. On the other hand, we have some patients with a very good diabetes control who do progress with the disease. So are there certain local factors that are acting? So we came up with the objective to assess the levels of various biomarkers across different pathogenic pathways in diabetic retinopathy in serum and vitreous and correlate their levels with the traditional blood systemic investigations that we are routinely doing in the patients of type 1 and type 2 diabetes. And we also compared and contrasted them among the patients of type 1 and type 2 diabetes mellitus patients with PDR. It was a cross-sectional observational control study with a sample size of about 40 patients. The 10 vitreous samples were taken from patients of type 1 diabetes mellitus, that is juvenile onset diabetes. 20 samples were taken from type 2 diabetes mellitus because they were more common naturally. And 10 samples were used as a control from the patients of macular hole who did not have any systemic illness. So we screened the patients in our OPD, assessed their best corrected visual acuity, IOP, did fundus evaluation and included them into respective groups. Then we did blood sampling for those patients and evaluated hemoglobin levels, blood sugars levels, RFT, HbA1c, and also we took the plasma of the patient, centrifugated it to calculate to assess the levels of VEGF, glutamate, renin, angiotensin, TNF1 alpha. Also, these patients underwent vitrectomy and we took about 0.5 ml of undiluted vitreous sample and evaluated again it for renin, angiotensin 2, VEGF, TNF alpha and glutamate. As you can all see that we had the factors from various pathogenic pathways. So for the ease of understanding, we divided our study into 4 basic steps. First of all, we tried to establish whether these biomarkers were elevated in the plasma and the vitreous as compared to the controls in both type 1 and type 2. As you can see, all the 4 top tables, we can see there is a statistically significant difference in the levels of VEGF, glutamate, angiotensin 2, renin and TNF1 alpha in both the groups as compared to the control group, which were macular hole patients. On step 2, again we wanted to evaluate whether these factors were increasing in a linear pattern in both plasma and the vitreous. So we found that it was only plasma VEGF and vitreous VEGF levels that were linearly correlating. Other did not show any significant correlation, which means that when a serum levels of VEGF were going up, similarly in a similar fashion vitreous VEGF levels were going up. However, this pattern was absent in other 4 factors under evaluation. So for step 3, then we correlated these factors with the traditional blood investigations, that whether FBS, RBS, HbA1c levels were linearly correlating with the levels of vitreous and serum levels of the biomarkers under study. So in this table, as we can see, the yellow ones are the type 2 diabetic mellitus patient. We can see all the blood parameters seen on the left were correlating with the levels of renin, VEGF, angiotensin and TNF in type 2 diabetes patient. However, in case of type 1 diabetes patient, it was only VEGF levels that was linearly correlating with these blood investigation. Similar was the pattern with the vitreous levels of all the biomarkers under study. The fourth and the final step of our study was to contrast these factors among type 1 and type 2 diabetes mellitus patient. As we all know, there is a significant difference in the pathophysiology of both the types of diabetes. So what we could see was both the groups were comparable in terms of blood investigation, except the nephropathy was more common in type 1 diabetes patient, which was a statistically significant result. And on comparing plasma levels of these biomarkers in type 2 and type 1 diabetes mellitus, we found that angiotensin 2, renin and TNF alpha were markedly elevated in type 2 diabetes mellitus patients in plasma as compared to type 1 diabetes. And the vitreous levels, again we contrasted them. It was VEGF levels that was seriously very high in cases of type 1 diabetes mellitus patients in vitreous as compared to the type 2. So coming on to the discussion, there have been various pathways under evaluation. The progression of DR definitely depends upon the glycemic control of the patient. All these factors under evaluation were such chosen that they were the representative of the different pathways. So we came up with a conclusion that in type 1 diabetes mellitus, it was angiogenic pathway that was predominant. So again, anti-VEGF therapy continues to be a very strict and a very effective therapy in type 1 diabetes. However, in type 2, there were other pathways like TNF alpha, indicating inflammatory pathway, RAS pathway, renin and angiotensin that were elevated and therefore need a newer therapeutic interventions that need to be explored for treatment of type 2 diabetes mellitus with diabetic retinopathy. Thank you. Sir, what was the outcome of this study was there have been many such studies, but the thing was that in a single cohort of patients, we evaluated all the pathways, representative markers of all the pathways. So what we came up with the result was that in type 2 diabetes mellitus, even in the vitreous, there were inflammatory factors that were elevated. So it is not only the VEGF that was the causative agent for causing the proliferation of the disease, it was renin levels, angiotensin levels, as well as inflammatory pathways indicated by TNF alpha and glutamate in our study that were represented. So we need to explore certain therapies that we can limit these factors locally as well, which can decrease the progression of the disease.
It was nice presentation. Which kit was used for?
Human ELISA kits were used.
Indian based or Germany based company?
Indian based, ma'am.
Indian based. And how it will contribute according to you?
Ma'am, as I said, basically currently what we are practicing is we are only giving anti-VEGF. We have very narrow approach to restricting the pathway. Like we are only inhibiting VEGF levels in the pathway, and we have come up with faricimab, which are again more or less related to angiopoiesis only. So what we bring up with this study is there are other pathways like certain anti-inflammatory agents that can decrease or bring down the levels of TNF alpha, certain agents that can bring down the level of RAS and angiotensin. Like for hypertension, we decrease the level of RAS and angiotensin systemically to control the hypertension. Can we explore something locally to decrease these levels, which might be causative especially in type 2 diabetes mellitus patients?
So what was the inclusion criteria? They were lasered patients or unlasered patients?
They were the patients who had indications of vitrectomy. We did not strictly mark them whether they were lasered or unlasered.
Okay, that was the...
And another shortcoming that I am pointing out myself is that we also had certain hypertensive patients which were on ACE inhibitors and RAS pathway inhibitors. So that can be a shortcoming in our study that might be affecting the levels of these factors even locally.
Thank you, Dr. Vineet. I think we move on to the next by Dr. Bhaskar on incidence of aggressive ROP and management with biosimilar. Next speaker, I would request Dr. Pragati Raj to be ready for the next talk. On the podium when almost he finishes, maybe after a couple of minutes.
Good morning, everybody. Thank you, AIOS, for giving me opportunity to present my study on incidence of aggressive ROP and management with biosimilar ranibizumab and laser in tertiary eye center in Eastern India. So ROP is a vasoproliferative disorder of premature low birth weight infants featuring abnormal proliferation of developing blood vessels at the junction of vascular and avascular retina, with key factors involved are VEGF and insulin-like growth factor type 1. According to ICROP, these are the ROP zone classification, and these are the stages of ROP. According to ICROP, aggressive posterior ROP is a severe variant of ROP which includes zone 1 and posterior zone 2 with increased dilatation and tortuosity with posterior pole vessels in all 4 quadrants and a rapid progressive course. Biosimilar ranibizumab is a recombinant humanized IgG type 1 monoclonal antibody which is formulated for intraocular use of DME, CNVM and macular edema. Innovator ranibizumab still remains a cost-prohibitive option for a majority of population in developing country like us. Aims of our study was to find out the incidence of aggressive ROP among the all screened premature children, babies, and efficacy of intravitreal biosimilar ranibizumab, followed by panretinal laser treatment of for these babies. This was a retrospective study carried out in a Vitreo service department in the tertiary eye care center in Eastern India after local ethical committee clearance and informed consent from the parents of the babies. We calculated the incidence of aggressive ROP, and the infant was given intravitreal biosimilar ranibizumab, and after weekly follow-up in case of persistent avascular retina, laser photocoagulation was done. Treatment of aggressive ROP babies being done with injection and laser. Among the 522 babies, those were screened for the study, 24 babies was found to have APROP disease, were given razumab injection, and after median of 5 weeks, they are lasered. In 50 babies, we found type 1 disease, were given laser only, and for 448 babies was normal. Complete resolution of ROP was seen in all 48 eyes. From the data from 48 eyes of these 24 babies having APRP was analyzed, and was found that after 5 weeks after treatment, zone 2A vascularization was seen in 10 or 76% of ARP babies with zone 1 disease, and 72% babies with ARP zone 2P disease. And after 5 weeks, zone 3 vascularization was seen in 7% of the ARP zone 1 babies, and 27% of the zone 2P ARP babies. Limitation of our studies was it was a retrospective study with very small sample size without any comparison group or any wide field imaging. Laser was planned after a fixed interval for all babies to avoid disease recurrence, repeat injection, or possible general anesthesia. And long-term follow-up data would improve the safety analysis. To conclude, incidence of potentially blinding AROP is not insignificant in Eastern India. Biosimilar ranibizumab is followed by laser photocoagulation is a safe, economical, and effective treatment option. And all eyes could be managed well with single anti-VEGF injection and single setting of PRP laser. And there is no safety concern in the short-term follow-up. This is the review literature by Dr. Lalit Verma et al. And Dr. Prajapati. Thank you for your kind attention.
It was a very nice study. After how many days the laser was carried out?
A median of 5 weeks, average 3 to 6 weeks.
Okay.
And after examining the avascular retina.
Avascularity. If it still persists, are there any number of cases in which you don't need any laser? You didn't need, huh?
Actually, we did laser in all the cases after this fixed period to avoid any possible recurrence of disease or the babies growing. So it will be difficult to examine or treat them under topical anesthesia without any general anesthesia backup. So that's why we did laser after a fixed time.
Okay.
Do you think it is just
Yes. It was a blanket therapy laser. Okay. Thank you, sir.
So we move on to the next presentation by Pragati Raj on efficacy and safety outcomes of intravitreal brolucizumab injections, ENSURE study.
Good morning, everyone. I'm here to present the study, ENSURE study. There is no financial interest or conflict of interest. So there are numerous retinal and choroidal pathologies like DME and neovascular ARMD that is predominantly driven by VEGF, and anti-VEGFs have been a standard of treatment. The most recently approved is the anti-VEGF brolucizumab and faricimab. Discussing the brolucizumab, it is a humanized single-chain antibody fragment that inhibits all isoforms of VEGF-A, and since it is only the variable part of the antibody, so it has the least molecular weight amongst all, and that enables us to give a high molar dose with high drug concentration, and it increases the duration of action. And it also has 11 times more VEGF binding capacity than aflibercept and 22 times more than ranibizumab. It was introduced in the global market as Beovu in October 2019, and in India as Pegenex in October 2020. The landmark trials being Hawk and Harrier and the Kestrel and Kite that was done for neovascular ARMD and DME respectively, and it was seen to be non-inferior to 2 mg aflibercept, and also the rate of side effects that was seen was approximately 2 to 4%. So the safety concerns have been raised due to incidence of intraocular inflammation in eyes receiving brolucizumab, and many centers had either stopped the usage or reserved it for resistant cases. So a retrospective study was done at a retina clinic of Tertiary Eye Care Center in Bangalore from October 2020 to January 24, and only cases injected with brolucizumab injection was taken into consideration. The methods include the data collection of demographic details, the laterality of the eye, visual acuity pre and post injection, indication of injection, disease diagnosis that included both on and off-label diseases like macular edema caused by vascular occlusion and DR and post-PPV, and choroidal diseases like CNVM caused due to ARMD or myopia, choroidal osteoma, and pachychoroid-related diseases. Also, the treatment history was seen, that whether the patient was treatment naive or treatment switch, and follow-up details that was seen with the visual acuity ETDRS letter and the OCT that included a central subfield retinal thickness and the fluid and hemorrhage conditions. And also the safety information was taken between 4 to 8 weeks after the injections, including the anterior and posterior segment inflammation. So the inclusion criteria included the treatment naive and the treatment switch case with the details we had from 4 weeks to 8 weeks after the injection, and all other cases were excluded. So for results, there are 926 injections were given within the period, and that included 237 males and 153 females, with retinal pathology being 183 and choroidal pathology being 267, and the treatment naive cases being 135 and switch being 315, and average number of injections was 2.4. The most common diagnosis for which injection was given was neovascular ARMD, with 48% and 24% being DME, and all other diagnoses. So it was seen that the statistically significant decrease in CSFT was observed, and resolution of PED, SRF, and IRF was seen in cases when retinal and choroidal pathologies were amalgamated together. In cases of choroidal pathologies, the vision deteriorated, but the CSFT improved, and PED, SRF, and IRF resolution was seen, and 18% cases had to be switched to other modalities of treatment. In retinal pathologies, vision also improved, as well as the CSFT reduced significantly, and PED was not found to be, resolution was not found to be significant, but SRF and IRF was found to be significant. So as a comparison, a statistically significant improvement in visual acuity and a significant reduction in CSFT following injection of retinal pathologies was seen. And on the safety outcomes, 3 cases of intraocular inflammation was seen, with 2 being anterior segment and 1 being posterior segment, and that needed the PPV, but the vision was restored. So the incidence was 0.3% per injection, 0.7 per eye, and 0.8% per patient. So a real-world brolucizumab study demonstrated improved anatomical outcomes for both retinal and choroidal vascular pathologies, but demonstrated visual improvement only in the eyes treated with retinal pathologies. Lower incidence of IOI and RV was seen compared to the clinical trials. So we conclude that intravitreal brolucizumab should be continued for different retinal and choroidal pathologies with proper monitoring of patient symptoms. Thank you. Yes, yes. So in
Okay. From 30%, the incidence you say is less than 1% here.
yeah,
So 30-fold decrease. First thing, I don't think anywhere it is reported about 30%.
30%.
No.
1.7 in VRSI. The study in VRSI is 0.7 to 1.7.
No, somewhere you have written that it is 30% in various studies or some studies. First or second slide. I don't think 30% is ever reported. The latest study, Merlin study, also says it is 11%, which is also too big, too high an incidence. In your case, in your series, the incidence is too low. So what you think is the probable cause?
Sir, in our case, the most common regimen that we followed was PRN regimen. So that could also be a cause, because we were just assessing the patient, and according to the disease activity, we were injecting the patient. So that could also be a cause for decreased number of injections that we gave. The average number of injections were comparatively lesser than the other studies.
Is there any data on this? The maximum number of injections given
Ma'am, in Hawk and Harrier,
in
they,
your study?
yes ma'am, it was 2.4.
2.4.
Yes, ma'am. A range of 1 to 18.
Thank you.
Thank you.
Next, Dr. Rahul, you can start with the presentation.
Very good afternoon. At the onset, I'd like to thank All India's AIOC for giving me the opportunity to present our case on comparative study on rules of innovative bevacizumab versus biosimilar bevacizumab in the management of ROP. Excuse me. Yeah, so no financial disclosure associated with my studies. Retinopathy of prematurity continues to be a significant clinical concern in neonatal medicine, affecting the visual development and the quality of life of premature infants worldwide. The pathophysiology of ROP is intricately related to the aberrant vascular development with the developing retina of premature infants. As one of the leading causes of childhood blindness, ROP underscores the need for effective, accessible, and the cost-efficient treatment. Traditionally, therapeutic intervention of ROP have relied upon ablative treatment like laser photocoagulation, which while effective can carry the risk of peripheral visual loss and damage to the developing retina. So we all know the importance of VEGF in the pathogenesis of retinopathy of prematurity. Now, the advent of antivascular endothelial growth factors such as ranibizumab and bevacizumab agents have transformed the treatment of the landscape of ROP. Bevacizumab, a humanized monoclonal antibody targeting VEGF, has gained substantial attention for its remarkable efficacy in treating various ocular neovascular diseases in adults. Treatment with anti-VEGF injection lead to regression in the acute phase of ROP, as well as it enables the normal development of the retinal vasculature. These were the landmark trials of anti-VEGF in the retinopathy of prematurity. Initially, we had the BEAT ROP, then we had the Firefly ROP and the Rainbow trial, which showed the effectivity of ranibizumab. The introduction of biosimilars, which are biologic products that are highly similar to the reference innovator molecule, have the potential to revolutionize ROP management. They offer a unique opportunity to expand access to cutting-edge therapies while potentially reducing the economic burden associated with the disease. So our objective was to compare the role of innovator bevacizumab with an Indian biosimilar bevacizumab for the management of type 1 ROP. So it was an interventional single-center study conducted at a tertiary eye care center in Jharkhand. The study period was from June 2022 to January 2024. It was carried out in accordance with the tenets and outlined in the Declaration of Helsinki, and after receiving approval from our institutional review board. The parents or the legal guardian of each child provided written informed consent for the treatment and the data collection. After doing a proper ROP screening, a comprehensive history and a fundus examination, we graded the ROPs by using the ICROP classification. Now, type 1 ROP was characterized as any ROP with plus disease in zone 1, stage 2, 3 ROP with plus disease in zone 1, and the third was stage 2 or 3 ROP with plus disease in zone 2. Infants with type 1 ROP received 0.625 milligram of intravitreal bevacizumab, both innovator and biosimilar, in the operation theater under aseptic condition. Those eyes whose ROP worsened later received laser photocoagulation after 28 weeks following injection of bevacizumab. So a total of 72 eyes were chosen for this study. 36 eyes were on innovative bevacizumab, and the rest 36 eyes were on the biosimilar bevacizumab. Weekly follow-up was done. If the ROP worsened, we moved to the laser treatment, and if the ROP regressed, we kept the patient to do follow-up until the 24th week. Statistical analysis was used by using SPSS 23. Now, in our study of 72 eyes of 36 infants, out of which 36 eyes received innovator bevacizumab, and the 36 eyes received biosimilar bevacizumab. The mean gestational age was about 28.9 weeks, and the average birth weight was 1.19 kg. The gender distribution exhibited a modest male preponderance, with the male comprising about 58.3%, and the female about 41.7% of the study group. Now, the treatment outcome: by 24th week after the commencement of treatment of the 72 eyes, in the innovator group, 31 eyes had complete regression of ROP. In the remaining 5 eye, additional laser photocoagulation was done. In the biosimilar group, 29 eyes showed ROP regression, and the remaining 7 eyes had to give on additional laser photocoagulation. But all of them displayed complete ROP regression after 24 weeks of commencement of treatment. So our study did show that the innovator bevacizumab and the biosimilar bevacizumab had a very good efficacy, and the safety and there was relatively no safety issues, either ocular or systemic. Of course, anti-VEGF therapy does offer several advantages over laser photocoagulation in our patients, and it is essential to recognize that although biosimilar provide cost saving and are intended to closely match the reference product, they may not be identical. As a result, healthcare providers and patients should collaborate to make well-informed treatment choices on the specific clinical context. Our study is limited by a sample size and a short follow-up period. So to conclude,
Dr. Rahul, please sum up.
Biosimilars are effective and and have got a very good safety profile. Thank you.
The study was very good, but the time consideration is very important.
Yes, ma'am. Yes,
That's all.
that's what we emphasize, ma'am.
Sir, any question from you?
No, good study, but we should be careful while using, bevacizumab in ROP babies, and that too biosimilar of bevacizumab.
Agreed, agreed, sir, agreed.
We should be careful.
Yes, sir,
There
agreed.
are so many medico-legal issues.
Definitely.
Thank
So
you.
documentation is very important.
Of course, ma'am, of course, ma'am.
You must have show the records also, how to maintain the record.
Okay.
So that is very important for the audience also.
Right, ma'am.
So do biosimilars of bevacizumab have DCGI approval in India?
Sir, for ROP still we don't have any approval.
So
So
did you
because
get the ethical clearance for that? Because if you don't have the approval in India for biosimilar bevacizumab in ROP, so that might be a problem.
Yes, sir. Anyway.
The next,
Thank
Dr.
you.
Mrinalini is here. Dr. Mrinalini. Subsequently, Dr. Ruchi Agarwal. Then I invite Dr. Shweta Parak for her next presentation on intraocular inflammation following intravitreal faricimab or experience.
Good afternoon, everyone. I will be presenting on IOI following intravitreal faricimab. Faricimab is a novel bispecific monoclonal antibody that targets both VEGF-A and angiopoietin-2 and has been approved for wet AMD, DME, and retinal vein occlusions. Ours was a retrospective case study carried out over a period of 8 months. All patients underwent thorough pre-op and post-op injection evaluation on the given days. In our series of 26 eyes with 24 patients who were injected, maximum number of 2 injections of faricimab were given, and we have seen 3 cases of IOI following injection faricimab. This is in comparison to 3 out of 42 eyes of injection brolucizumab that were given at our center, which had IOI. Coming to the cases, 73-year-old male with bilateral IPCV and who had received 10 intravitreal Eylea injections in the past, was not responding well to the injection, and the decision was made to switch to faricimab. However, on the 7th day post faricimab, he presented with vitreous cells 1+, and he responded well to treatment with topical prednisolone acetate. There was no evidence of vasculitis or vascular occlusion. The second case was that of a 68-year-old lady with wet AMD OS and who had received 4 intravitreal ranibizumab 12 Eylea in the past. There was a history of mild vitritis following one injection of brolucizumab in the past. She was made to switch to faricimab in view of non-response to other injections, and she presented similarly with Vitcells 1+ on day 7 post-intravitreal faricimab. There was no occlusion, and topical steroid therapy was used, and she responded well. 81-year-old lady, this was the last case of a wet AMD patient who presented on day 1 injection post-faricimab with multiple pigmented KPs and no evidence of vasculitis or vascular occlusion. She also responded well to treatment with topical steroids. She happened to be suffering from osteoarthritis, and she was on treatment for the same. Reports of IOI following injection faricimab are uncommon. They are statistically higher than that of the ILEA group, but not as high as pegcetacoplan or brolucizumab group. This was a case series of 71 eyes, which showed similar presentation to us in the form of mild vitritis without vasculitis. And there have been reports of severe IOI in this case series of 3 patients from a single institute, one of whom required a therapeutic vitrectomy on the first day following presentation. There have been reports of bilateral occlusive vasculitis following injection faricimab, and also those of uveitis. Sterile IOI can present either as a severe acute onset inflammation mimicking infectious endophthalmitis, or a delayed onset inflammation, which has been seen more with injection brolucizumab and pegcetacoplan, and more in the form of an occlusive branch arteritis at branch arterioles. A history of uveitis, the use of pro-inflammatory prostaglandins, and the history of diabetes and AMD can also contribute to IOI. The presence of treatment-boosted anti-drug antibodies, especially high after brolucizumab, also lead to high incidence of IOI. The FC region of the anti-VEGF molecule is a highly immunogenic factor, and it is noticeably absent in the ranibizumab molecule. Faricimab has a modified FC region which reduces the incidence of IOI. Bacterial endotoxins, impurities, and proteins from other human sources, syringe agitation, freeze-thawing processes, shipping and handling may all contribute to IOI. Steroid therapy forms the mainstay of treatment. In severe cases, even vitrectomy may be warranted. In order to compare with the incidence of IOI following brolucizumab-induced injections, this was a meta-analysis of 31 reports of 41 patients with 46 eyes, average age 76 years old, with 58.5% being female, and IOI occurring at a median of 37 days after treatment initiation, with average of 2 injections. To summarize, at our center, we have come across post-injection faricimab 2 cases of mild vitritis and 1 case of anterior uveitis, and there was no associated retinal vasculitis or occlusion, and they responded well to topical steroid therapy. There was history of IOI in 1 lady following IVT brolucizumab in the past. This may have made her more prone to IOI. In conclusion, drug-induced uveitis is a rare adverse effect of drug administration, and early diagnosis and treatment can prevent severe visual impairment. There have been few reports for IOI following injection faricimab, and steroid therapy forms the mainstay of treatment. Thank you.
Thank you, Dr. Swati.
Shweta.
Shweta.
Thank you, sir.
Yeah, one point you also pointed again that one patient who has had brolucizumab and reacted or had some reaction because of that.
Yes.
Don't you think we should have been more careful in injecting?
Yes, sir, definitely.
Or not injecting, or thinking second time, twice before injecting?
Yes,
because
sir.
maybe that patient was prone for infection.
Sir, I agree, but we had run out of options as far as the treatment was concerned, and there was absolute non-response. In fact, after the IOI following brolucizumab,
So did you
she
take
was
any
switched back to
special-
ILEA.
Did you take special precaution for that patient who has
I
had
agree,
some
we should
reaction?
have maybe preemptively put her on topical steroid therapy. I agree, we should have done that.
And some conjunctival swab, etc., microbiology of the
No,
conjunctiva.
sir, there was
laid-
no infective etiology as such, but I agree, we could have at least put her on topical steroid therapy preemptively.
So, do we need any precautions so that we should try these injections, faricimab and brolucizumab, Precautions, which patients are in which
More
we
prone.
should be precautious to use these?
Those with using prostaglandin analogs or AGMs in particular, those with history of AMD and diabetes, yes, theoretically, yes. Especially those with a history of uveitis, then be more careful.
And some systemic issues, as in one case you have shown
Rheumatoid.
that rheumatoid arthritis.
So that is one angle that we are just trying to explore. The patient was anti-CCP, anti-RA factor also negative. We were trying to explore and look into that angle. Is there any, so far we have only come across 3 cases, not come across any other patients. In fact, in the IOI series of brolucizumab injection, one patient had vasculitis with disc edema and happened to be suffering from Crohn's disease. Although it's not enough to come to a conclusion, but we are looking into that also well.
Thank you.
One more thing, just for the audience. On the contrary, in brolucizumab studies, they have said the incidence of IOI is less in diabetics as compared to non-diabetics. Okay, on the contrary.
Yes, sir.
Thank you.
Thank you, sir. Thank you.
Thank you. Next, Dr. Ansari is here. Dr. Ansari. Then we move on to Dr. Chandar Prabha. Dr. Chandar Prabha. She is also absent. Then Dr. Priyanshi. Dr. Shushmita.
Anyone who is sitting here has to present.
Any speakers, please come forward.
No one is left, I guess. With
Then we will wind up with the session. Please come forward.